Candidate 1.
Yes.
So this is your first case. This is a 74-year-old, excuse me, male, came to A&E, brought in by the ambulance. He was found snoring at his home, unresponsive. So over to you.
Okay. Now I have the control.
Yes, you have got the control.
Yes. I have been presented with brain CT scan without IV contrast for an adult male patient presented to the A&E with a history of snoring and not responding. First, I will scroll through the images until the last cut, and then I will come back to my finding. I didn't catch any significant abnormality within this non-enhancing CT scan, so I will go through my checklist. First observation, I noticed that there is a hyperdense signal seen involving the basilar artery. The basilar artery appear normal in size. I cannot see any other hyperdense signals such as dense MCA sign. I cannot see any obvious space occupying mass lesion in this non-enhancing brain CT scan. I can see that the cerebellum and the foramen magnum appear within normal. I will quickly check the vertebral arteries to see if there is any abnormality. I cannot see any abnormality within the vertebral arteries. Also, I cannot see any dilatation within the ventricular system, and also there is no shift of midline structure. So the main abnormality, I can see that there is hyperdense signal seen within the basilar artery. In my routine practice, I am thinking about concept of basilar artery thrombosis. In my routine practice, I will advise to do neck and intracranial CT angio to rule out any filling defects.
Here you are. Here you are.
Yes, this is neck and intracranial CT angio. I can see the arch of the aorta and its branches, the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery appear normal without any stenosis, plaques, or ulceration. The vertebral arteries, both of them, appear also within normal. I am going up. Here I can see, yes, it is normal. I am going up until the basilar artery for assessment of the, it's a little bit lagging. Okay, in the basilar artery, I can see that there is loss of the enhancing pattern of the normal basilar artery seen proximally. This confirms the presence of filling defect representing basilar artery thrombosis. I can see
What will
normal
you do
enhancing.
next? What will you do next?
First, I will urgently confine my finding to the neurosurgical team to see if the complaint has less than 6 hours, to see if there is any benefit of the thrombolysis. If it is more than that, I will contact with the interventional radiologist team and arrange for urgent thrombolectomy.
So what is the time limit for, posterior circulation thrombectomy? You just mentioned 6 hours, isn't it?
Yes.
Okay, we'll stop there. Thank you. Let me go through the teaching points on this case. Candidate did very well. Well done. Now, today, one thing which I forgot to tell you that I've selected a few cases which is large pelvic lesions with unusual presentation. So I'll show you cases, quite a few cases, and they do come in the exam. Even this time, some of you got similar cases. So that is a theme which I will go through today. Now, this case one is basilar artery thrombosis. Key thing here, as the candidate did very well, that was to go through the viewing protocol quickly, did not pick up anything, and then the candidate start going through the checklist or the viewing protocol, and very soon actually did pick up the basilar artery thrombosis. So again and again, I cannot overemphasize this. We have done this many a times, but this is what satisfaction of search is also about. Viewing protocol is the key, and this is the difference between safe and unsafe radiologist. So you must practice it, practice it, practice it. And this is the viewing protocol, which of course I've gone through with you many a times. You can take a screenshot again. I don't have a time to go through it again, but please remember that in the exams, they are trying to check your viewing protocol in a way, satisfaction of search in a way, are you a safe radiologist? Please always, arteries and veins, pituitary fossa, but please also remember to ask for the bone window and also see for extra calvarial or extra brain, extra neuro type of findings also. Now, a few points about stroke. There is a window, we call it the stroke window. These are the window width and level. 8 is the width. Level is 32 and 8th is the width. So on this window, this is the type of image which you get. And in your routine practice, if you develop your clinical practice to look at this window, it's a very useful tool. And the sensitivity actually increases if there are some studies published on this. Basically, the gray-white matter differentiation becomes more accentuated. So try to develop it. In brain, I think there are 4 windows which should be in your mind. One is the brain window, regular brain window. Then is the bone window. In every case, you have to see both of them or ask the examiner that in my usual practice, I review the bone on a bone window. If they want to show you, they will show you, otherwise they will not. Then in acute trauma cases, go for a subdural window, subdural hematoma window, or whatever you want to call it, where a subtle subdural hematoma is better seen, otherwise you will miss it because of same density like adjacent calvarium. And finally is the stroke window. So my advice is try to see it, develop your eyes on in your day-to-day practice. Look at this lentiform nucleus, and the lentiform nucleus is lost here. Of course, you can see it here, but it really increases your level of confidence. And the insula, if you see the insula here, what says, abnormal insula here. This is another case of basilar artery thrombosis, just like the one which we saw right now. This is a different patient, and in which you can see that the basilar artery is dense. So basilar artery is your friend for the exam. You must see it. And at times, is contrast given to the patient or not? You can pick it up by looking at the basilar artery. So it should be part of your protocol. Now, once you pick up a acute thrombus in the basilar artery, try to look at any stigmata of developing or developed acute infarction in the posterior fossa. So particularly look at the cerebellum and the brainstem. The problem is that you will never be confident in the brainstem because there are many artifacts coming from the petrous bone. But more importantly, look at the occipital lobes. Occipital lobes here in this case are fine. But do not forget the thalami. Point to remember is that the thalami, part of the thalamus is supplied by the posterior circulation and part by the MCA. So that's a key point to remember. And you might like to impress the examiner that I can see subtle hypodensity in the thalamus here. I'm not very sure if this is artifactual or not, but here I think there is something. Overall, this is basilar artery thrombosis. Uh, Same case after 2 days, and you can see that thalamus infarct, and you can see a well-developed infarction. Key point about thrombolysis is, or thrombectomy, you should have clear-cut concepts about this, that when intravenous thrombolysis, the first studies which were published in 1995, they proved that you have got a window of 3 hours. Gradually, studies told us that you can increase the window to 4.5 hours. And in selected cases, some people even go beyond that. But for intra-arterial, we used to do intra-arterial thrombolysis. The window was 6 hours. Now, the procedure which is done is intra-arterial thrombectomy in UK, because they have got devices like snares or some fancy at times drills, etc., where they can remove the thrombus. And the window for anterior circulation is 6 hours, but for posterior circulation is 12 to 13 hours. So remember that. You are not going to lose anything, even if it is more than 12 hours. So for posterior circulation, intra-arterial thrombectomy is more. The window is much more. Candidate 1, you did very well. So the only fine touch is this one factual point which I told you about posterior circulation, intra-arterial thrombectomy. Otherwise, you did very well. So let's carry on with your Now, this is a case of 71-year-old male, loss of weight, and they are worried about malignancy. So it was a CT, chest, abdomen, and pelvis. And because of time factor, let me show you the chest part. I'm just going to go through the chest part instead of giving you the mouse. You can see the finding on the chest part. And now we are in the abdomen. So candidate 1, can you take the mouse, please?
Yes.
Over to you.
Yeah,
Please concentrate on the pelvis.
Yes, I have been presented with abdomen and pelvic CT scan axial images for 71 male patients.
And that, excuse me, that doesn't mean that you don't have to look at the upper abdomen, but concentration should be there.
Yes.
So,
with a history of weight loss to rule out any malignancy, I will scroll through the images until the last cut of the pelvis. Okay. Now I am back to my finding. First, I noticed that there is abnormal, complex, cystic, and solid lesion noted in the pelvis, which is located in the anterior aspect of the sigmoid and rectum colon and seen posterior to the urinary bladder. I can see that there is loss of cleavage line between the mass lesion and the urinary bladder, and also I can see that there is focal thickening of the urinary bladder wall posteriorly. I will check if there is any significant periregional lymph node enlargement, which I cannot see any, and I cannot see any free fluid. This mass lesion causing a compression effect on the left ureter. I can see that there is changes of hydroureter, and also by getting upward, I can see that there is a left-sided mild hydronephrosis, and I can see that there is differentiation in the enhancing pattern between the right kidney and the left kidney. There is hypoperfusion of the left kidney, so this raising the possibility of obstructive uropathy. Also, I want to check the rest of the abdomen to see if there is any metastatic deposit, which I cannot detect any. And also, I want to check the liver to see if there is any metastatic deposit. I cannot see any clear metastatic deposit within the liver, although I can see that there is lesion noted in the right liver lobe in the segment 4A, which showed calcified foci. Otherwise, the liver surface looks smooth without any intrahepatic biliary dilatation. I want also to check the bone window to see if there is any metastatic deposit.
Just concentrate on the pelvic mass and tell me what it is.
Yes. So basically, this is a complex cystic and solid lesion seen in the pelvis. This mass lesion showed in the solid part of this lesion showed avid enhancement with the IV contrast. The epicenter, I want to see if it is connected to the any of the organs surrounding it, such as the prostate. In my routine practice, I want also to check the sagittal images.
So the sagittal is with you. Let me place it better for you, and maybe slightly. Now over to you, please.
Yeah. In this sagittal images, I can see that the mass lesion is also not clearly separated from the prostate, and also I can see that there is focal defect seen in the posterior wall of the urinary bladder. I can see that there is a clear cleavage line with the rectosigmoid column. So mostly this mass lesion is from prostate origin, because it have a large contact surface with the prostate.
What would you like to do to confirm your findings?
Yes. First, I will check the bone window to see if there is any diffuse.
No, I'm not interested in bone window. The mass itself, how will you like to evaluate this?
How to evaluate the mass?
Yes, you have said that I think this mass is arising from the prostate. How can you confirm it? What modality will help you to confirm it?
Pelvic MRI can be helpful.
Okay, I am going to give you a pelvic MR. Here you are. Over to you.
Yes, I have been presented with axial images of pelvic MRI, T2 sequence. I can see the lobulated heterogeneous signal mass lesion and the surrounding cystic structure. I want to see if it is related to the prostate. I can see the prostate with the zonal anatomy of it. I cannot appreciate if it is really connected in this sequence, so I may use the sagittal sequence if it is available.
So, sagittal, over to you.
Yes, this is a sagittal sequence. I can see that there is truly connection seen between the prostate and the mass lesion in this sequence, and I can see here that the mass lesion invading the posterior wall of the urinary bladder. This is explaining the defect that I saw in the chest CT scan. So my impression for this is lobulated soft tissue and cystic lesion within the pelvis, most likely arising from the prostate. In my routine practice, I will check the bone window in the CT scan and the lung window for this patient. I saw already that there is multiple metastatic deposit in both lungs. I want to check the bone window also to see if there is any widespread sclerotic metastasis. And I will also see the lab result for this patient to see if there is any rising in the prosthetic specific antigen level. And then I will combine my finding to the referral doctor and discuss this case with the oncology MDT team.
Why is there, you saw something upstairs in the kidney. So what's happening?
Yeah, and also the patient need urgent referral to the urology team to relieve the obstructive uropathy at the left side.
How will they remove it?
Maybe by inserting a double J catheter. This will be helpful.
Okay, we stop here. So this case is in the exam, unusual presentations of usual tumors is one of the things which is popular, and they can show you because if it is not an unusual presentation, then it becomes very easy, right? So this is a case of, let me show you a PowerPoint. I think this time the PowerPoint only contains the diagnosis. So this is a urinary bladder carcinoma in a large diverticulum. And there is, of course, left-sided obstructive uropathy and lung metastasis as you had picked up. Now, let me go through the case. Now, of course, upstairs, we did see that there were lung mets and the kidney findings were very well picked up. And this also tells you when there is hydronephrosis or obstructive uropathy, the attenuation or the nephrogram phase is delayed. And if you had an IVU, and please remember IVUs still come in the exam, though in UK they are obsolete, but they do ask IVUs. So whenever there is obstructive uropathy, one of the thing is delayed nephrogram or persistent nephrogram, etc., etc. So you can see, and this is what is happening. Look at the attenuation is slower or lower than the right side. Now, you had a mass. Now, on this mass, what is the fine touch? This is the urinary bladder. Now, as we go down, you can see calcification in the prostate. So this is the prostate. As we are coming up slightly, so maybe possibly seminal vesicles are here. They are not very well seen, but the mass, most probably invading the seminal vesicle. On the other hand, if we had to trace the ureter, so this is the dilated ureter where I'm pointing out this is the ureter, and then it is, it stops here, means that the mass is invading the left ureter, and that is why it is causing it. Now, you did very well where you ruled out possibility of sigmoid tumor causing this, because the sigmoid colon and the rectum can be separately seen with it. So you mentioned that there is, your final conclusion on this was that this is most probably prostatic, which is going superiorly like this. So if you see the epicenter of prostate is here, and usually it will go here, though it can go behind also. You did very well where you picked up this thing, and I thought you will get it because you actually mentioned a breach of the wall or something, and this was one of the main findings, and I thought you have got it. But the same thing on MR. Now, do you see this? This is that breach, but let me show you the axial first of all, where we saw this axial. So what is happening now? Look at the bladder. Bladder is trabeculated. There are multiple other trabeculae. So chronic, lower urinary tract obstruction. Then this is the mass. Now, this thing all is a diverticulum. There is a huge diverticulum of the bladder, and within which urinary bladder carcinoma is sitting. Now, if you see here, this is the left ureter, and it is here you lose it, it is invading. Sorry, it is invaded by the mass. So the ureterovesical junction, of course, is also involved. Now, if you go back to the basics and go back distally, this is the prostate, and maybe, Pyrex 3 type of abnormality. By the way, what happened was in this case, it was reported on CT that this is a prostatic malignancy, and then we did an MR, and this MR is a what we call a prostate protocol. So I've got all sequences for prostate on this one. Now, if you see, this is the seminal vesicle on right side, and this is the seminal vesicle on left side. It is invaded by the tumor. So if we go to, there is a fancy looking lymph node here, this sitting here. And if you go to the sagittal, just 1 second, where is the sagittal? This is the sagittal. You can see that defect. You look at this. This is the distal ureter and how it is invaded by the mass. One point which I just want to show you, just for your interest, is the DWI sequence. This is a DB1400 sequence for prostate, and you can see this restricted diffusion. One thing which I want to point out, that on a DWI sequence, lymph nodes are very well seen, and this is, that was in the obturator region, obturator canal region. So there is a lymph node which is very well seen here. So this is a UB carcinoma. Okay, well done. These kinds of cases can also come as a long case. Remember that. Okay, candidate 1, your last case is a CT abdomen, A&E, 74 male, absolute constipation, and pain abdomen, not passing flatus, obstruction, question mark. Over to you.
Yes. I have been presented with, sorry, I will ask for remote control.
Yes, it is with you.
Yeah, I have been presented with axial images of abdomen and pelvic CT scan with IV contrast for an adult patient with a history of presented to the A&E with the didn't pass flatus. I will take a quick look into the CT scan and then come back to my finding. I will go until the last cut. Okay, I noticed that there is multiple dilated fluid-filled small bowel lobes with normal appearance of the large colon. Appearances are those of small bowel obstruction. In the last cuts, I didn't see any hernial defect through the hernial orifices. I am now checking the small bowel lobes, I can see that there is normal enhancing pattern of the small bowel lobes. I cannot see any gas foci in the dependent wall of the small bowel, so there is no pneumatosis intestinalis. I am now looking at this segment. I can see that there is a slight thickening in the wall of the small bowel lobes. However, in my routine practice, I will also check the coronal images. In this image, I can see that there is laminated body or laminated structure seen here with some foci of peripheral calcification. I want to check the bowel distal to it to see if it is collapsed or not, to indicate if this is the cause of the small bowel obstruction. I want also to check if there is any evidence of dilatation or in the biliary duct or gas within the gallbladder. I can see that there is gas seen within the gallbladder, and I can see that there is fistular tract seen within the small bowel. I cannot see
Okay.
any.
What is your conclusion?
Yeah, this is a case of a small bowel obstruction caused by gallstone ileus, and there is no evidence of pneumoperitoneum or pneumatosis intestinalis. I will urgently confine my finding to the referral doctor and to take the patient to the surgical team.
Okay, thank you very much. Well done, well done. You've done very well.
Thank you, sir.
Now, this case was gallstone ileus. Ileus is a misnomer actually, and ileus means, stagnation of the motility, but it's more than that, it's obstruction. This is a case in which, usually in gallstone ileus, the most common site for the stone to get impacted is distal ileum or the ileocecal junction, for the simple reason that the caliber of the ileum is much smaller. But please remember, it can happen within jejunum, and beware of cases where it will erode into the colon. If I'm not wrong, I think this time you got it, isn't it, in the exam? Yeah, erosion into the colon and causing large bowel obstruction. Usually, it is secondary to when in the large bowel there is a diverticular stricture, etc. Having said that, this is another case in which you can actually see another stone here and the fistulous communication here. So gallstone, please remember that studies have showed us only 12.5 to 15% of them have got calcifications, which can be seen on X-ray. And similar, CT is not very good modality to pick up gallstones. Though in large gallstones, there might be, because these are cholesterol stones, there is calcification. Now, so one of the differential for gas in the biliary tree, when we use the word gas in the biliary tree, it can be within the gallbladder, as was present in our case, or it can be within the biliary tree itself, as in the the intrahepatic ducts. So this is what we are talking about, spontaneous biliary fistula, typically due to a large gallbladder canal eroding through a chronically inflamed gallbladder wall into the duodenum, plus minor colon, or less commonly hepatic flexure. Even here, they have written commonly hepatic flexure. So please remember that there can be a fistulous communication with the colon also. Now, let's go back to the case. Now, so it was very well done. Basically, we see small bowel loops which are dilated. And the key thing is, where is the transition point? So now the transition point in this case is a stone here. a stone here, and you can see a bit of faint calcification, which is peripheral. Key thing is what's happening proximal. So I'm going proximal, and where my mouse is, these loops are all dilated. Now let's go to distal. And when you go to distal, this is the loop, and then where my mouse is, you can see the distal loops where it turns on itself, and look, all of them are collapsed. And of course, in your day-to-day practice and even in the exam, you can ask the examiner that in my usual practice, I will like to review the same thing on and coronal, because coronal for small bowel is a key sequence. And you can see the same thing on coronal, where you can see this is the stone, and with a bit of calcification. Distal to that, this is the transition point, and then it twists and turns, and it goes into the pelvis and ultimately goes to the right side, etc. Well done. So candidate 2, are you with us?
Yes, sir.
Okay. So just 1 second, please. Now, okay, this is a case who is a 55-year-old male. He came to the hospital with tightness to chest and chest pain. There is some previous history of, cardiac intervention, PCI, etc. So he was shifted to the cardiothoracic center. And one of the relevant thing is that in the past, he is supposed to be a cocaine abuser. Now he says that I don't use it since the last 1 year or so. Uh, tightness of chest, the cardiologist initially investigated, uh, but they also asked for a chest X-ray, and they ruled out from the cardiac side. On this chest X-ray, do you see anything abnormal? Tightness of
Um, so I've been provided with the chest X-ray of this patient who has presented with complaints of chest tightness and chest pain, and I can see that there are various lines, probably ECG lines, and which imply that the patient is quite sick. And
Can you
um,
please concentrate on the mediastinum? Please concentrate on the mediastinum.
um, I don't see um, much. Maybe there is subtle widening in the mediastinum, in the superior mediastinum, but
And why do you say that? Which level are we talking about? You
sorry,
can
sir.
ask for the mouse and point it out to me. Point it out. Ask for the mouse. The mouse is with you,
Yeah.
and you say that there is mediastinal widening. So why
Um,
did you?
uh, I can see slight mediastinal widening over here in this region, uh, but otherwise the lungs look normal to me, and
Okay, well done.
the
So what
grades,
are you
yeah.
going to do next?
I'd like to proceed with a contrast CT for further
CT scan.
assessment. Yeah.
Yeah. So I have given you a CT. Over to you.
I'm not able to scroll the images.
Ask for the mouse once again.
I've asked. Uh, I've already asked for the.
So do you see that bar on the top, and you can
Yeah, I've gone through that only, and I've already taken the remote.
You know, you can actually, you are, I can see the mouse moving and you are moving it. So there is something happening.
Okay, but I'm not able to scroll the images up and down.
Okay, let me scroll it for you.
Okay.
So I am going to go towards the abdomen and we will
So I'm
come. What I'm going to do is slowly I'm going
yes.
to scroll till the top. I'll come back and that time you start describing. Now keep just looking. Don't describe.
Okay. Okay.
Don't describe.
Now I can scroll down.
Okay. Now please describe
Okay,
it.
I've been provided with contrast enhanced images, CT chest of this patient, and I can see that there is hypodense collection within the mediastinum, and there are air foci as well within it. So, as there is history of prior chest intervention, cardiac intervention,
That
so
intervention was
uh,
2 years ago. There is nothing acute.
okay. So, but then still I can see that there are there is evidence of collection along with air foci within the mediastinum, suggesting possibility of mediastinitis in this case. And besides mediastinitis, I can also see that there is pericardial effusion and some collection in the left paravertebral region in the lower sections. So, can I look at the cardiac chambers? The pulmonary arteries, they look normal to me. There's no evidence of pulmonary thrombus. The great vessels also look normal. Uh, the cardiac chambers grossly look normal to me with no thrombus. There's no evidence of any aneurysm or aortic dissection, which I can see. So, in summary, I believe that this is a case of mediastinitis. Uh,
Why has this occurred? Look at the upper level.
um, the upper sections, I can see that the branches of the aorta, they look patent to me. I cannot see any obvious cause here. So can you please scroll a bit down? It is mainly centered around the divisions of the aorta, the left subclavian and the left carotid.
What is the superiormost extent of this abscess?
Superior most extent is it's reaching up to this level. I can see it at this level.
So what level is this?
Um, it's, um, it's a level in terms of
Anatomy wise?
I think thoracic inlet. And
What is this structure here?
thyroid.
Right. And what is this structure here?
That's the cartilage. Thyroid lamina.
Right. So is this soft tissue normal versus this soft tissue?
No, there is definitely some soft tissue prominence here in this region. Yes, you can see that.
Look at the jugular vein.
The jugular vein is not opacified. Yes,
What does that mean?
it is thrombophlebitis, septic thrombophlebitis, probably of the jugular vein.
Is the left
Because
brachiocephalic seen?
it is probably following the course of the. Yeah, I cannot see the jugular vein, and I can see the hypodensity along with air foci, probably along the course of the jugular vein.
So what is your conclusion?
I believe that the jugular vein is um, there's probably a septic thrombophlebitis of the IJV, and which is further
Okay,
extending downwards.
coming back to the abscess itself,
Yes, sir.
what do you think is the source of this abscess? Would you like to see anything else?
There's some. This could be the source.
You do that. What will you like to advise?
I like to proceed with MR to see the
MR of what?
MR of the neck.
Patient is in an acute condition, and will you like to do an MR? Can it be
No,
something more simple?
no.
What will you like to do? More simpler. So we did a CT scan. Over to you now. Now, can you once again try to ask for the mouse and see if you can scroll it? I'm not
Okay, I'm giving up once again, and I'm again going to request remote.
sure. So I have approved this.
I've again requested the remote, and still not able to
Yeah.
scroll the images. Uh, yes, now I'm able to scroll, I think.
Please go on.
Yeah. So here again, I can see that the IJV is thrombosed. There are a few air foci along its course. So there is definitely septic thrombophlebitis of the vein. And I can see some soft tissue fullness, soft tissue thickening on the left side. This is the normal area of the so the nasopharynx area looks normal, and as I'm coming down, that is the oropharynx area, and this looks normal to me. But as I come further below, the area of the hypopharynx and the larynx portion, I can see soft tissue thickening on the left side.
Where is the larynx? Can you point it
This is
out
the
to me?
area of the hypopharynx,
Mhm.
piriform sinuses, and I can see that there is some soft tissue thickening all around in this region. I'm going to come down further. And I can lower sections as well. So it is extending almost all along the length from the level of the hypopharynx till here. So
Conclusion.
so this could be Um, Malignancy, air seeping.
So why has or how has all of this gone into the mediastinum? And what will be the source of all of this? What is happening? What do you think is the source? Can you
The
check the
source could
source?
be the soft tissue thickening, which I am seeing along the
Okay.
course.
Okay, thank you. I'll take over.
Okay, so
Very, very interesting case. It is hot off the press. Last week we saw it. As you picked up very well, incidental anterior mediastinal abscess, and clinically, nobody was suspecting it. But the key thing is that this abscess was coming from upstairs, as in the neck. And that was the key. One has to think what is happening. Of course, I gave you a hint there of cocaine, etc. And maybe the patient was socially also isolated and things like that. And when we did a CT of the neck, then the cardiologist actually examined the patient, and the patient had extremely bad dental hygiene. And there is an abscess there, dental abscess. And with that, all of this, you will not believe it, that this must be going on since ages. And with that, there was a secondary abscess extending to the mediastinum. Now, there are a lot of learning points, and this is the key case which I have selected today to do a bit of teaching on. And many cases which I am going to show you are just for pattern recognition, but this one is for teaching. Now, this is from your Chapman transspatial neck lesions. And so where a lesion in the neck, it goes from one space to a second space, what can that be? And infection is one of them. Uh, so it says, dental origin, most likely. Spread from superficial to deep, from deep spaces to mediastinum. Look at this. From deep spaces to mediastinum. And there can be, of course, rim enhancement, etc., etc. Now, let's go back to the anatomy. And what we are going to learn today is a revision of the neck spaces. A revision of the neck spaces. So the neck spaces, the current concept, the latest concept is that we divide it into a suprahyoid neck, which is this one, and infrahyoid neck, as far as neck is concerned. Now, the main concept is that there are layers of deep cervical fascia. You don't have to remember the layers, but basic concept is that because of that, there are spaces which have got particular contents, particular extent. And as a head and neck radiologist, you have to understand this anatomy. And key thing is in your head and neck or neck cases that you have to understand which space is the epicenter of the lesion. Please remember, our lesion was difficult because it was transspatial. It was not confined to one space. But having said that, the concept is that you have to place the lesion in a particular space, and then according to the radiological features, you can create a differential diagnosis. Now, key thing which I want to highlight in our case is the carotid space. Now, this is the carotid space. In the suprahyoid neck and infrahyoid neck, it is a continuous space. And so these are the spaces of the suprahyoid neck: pharyngeal mucosal space, parapharyngeal space, masticator space, parotid space, carotid space, retropharyngeal space, perivertebral space. So this one is what we are talking about. This is the carotid space. But in the mandible, so for example, so this is the mandible. This is the mandible, and you can see the teeth here. This is the sublingual space. This is the submandibular space. And of course, this purple one is the masticator space. This is the masticator space, which goes all the way up to the base of skull, which is surrounding the mandible. And so these are the key ones for our case. But of course, there are other spaces which will also be in, involved in this case. In infrahyoid neck, there are 5 spaces. In suprahyoid neck, there were 7. In infrahyoid is visceral space. This is the space which is surrounding the thyroid gland and the surrounding structures. It is quite unique. And there is a posterior cervical space, which is this one here, posterior cervical space. It goes all the way till the clavicle. But these 3 spaces, carotid space, retropharyngeal space, perivertebral space, they are continuous. So please remember, they were upstairs in suprahyoid neck and they are here. Now, taking this concept further, this is the carotid space, this is the prevertebral space, and this is the visceral space, which goes till the hyoid bone. Now, look at these names. This table tells you spaces, extent, and contents. And I just want to revise carotid space. Carotid space is from skull base till the aortic arch. Remember this, from the skull base to the aortic arch. Aortic arch is sitting in the mediastinum. Something which goes into the carotid space can go into the mediastinum. It's common sense. An internal carotid artery, internal jugular vein, cranial nerve 11, correction 9, 10, 11, 12, sympathetic plexus, deep cervical, lymph nodes. So all of these are the contents of it. And then we go to, so this is the carotid space. This is the masticator space. And we are at the level of the nasopharynx. We have come down to the level of the mandible. This is the mandible. This is the sublingual space. This is the submandibular space. This is the carotid space. This purple one is the masticator space. This is the parotid space. Key point to remember is that these are the main spaces which touch the base of the skull. And that's why pathology of the neck can go into the skull. We have covered it many times in the past, but just a revision that this is the masticator space, the purple one. This is the carotid space, where the jugular foramen and the carotid canal is there. This is the parotid space. Now, another space in the infrahyoid neck is a unique space, which is known as the visceral space. This is around the thyroid. This is hyoid bone to the mediastinum. So please remember, things in the visceral space can also go into the mediastinum. And goiter is a known example because goiter can go into the anterior mediastinum, and retrosternal goiter, etc., is a known entity. So these are the various components: thyroid gland, parathyroid gland, larynx, trachea, hypopharynx, esophagus, recurrent laryngeal nerve, etc. So with this background, let's go back to the case. Now, sorry, I think I have shared. So if you see this X-ray, the candidate did very well. Pick up the superior mediastinal widening. If you see here, this is the aortic knuckle, and superior to that, there should not have been any, this indentation or So the candidate did very well. We are picked up that there is superior mediastinal widening. That was the key thing here. Now, then I showed CT, and on this CT, again, well picked up. If you see these findings are, I'm not interested in these findings. There was some effusion, some consolidation. There was a incidental pericardial effusion, and look at this vessel. This is all calcified. Coronaries are calcified, but we are interested in here. Now, if you see here, this is an abscess, and look where it is. As we go superiorly, it goes, this is the arch of the aorta, and now it is encasing the vessels. So this is the subclavian, this is the left common carotid, this is the brachiocephalic, and it is going superiorly. So the key thing is, where is it coming from? That is the key. Now, the thyroid lobe is in view. Still, the abscess is visible. As we go superiorly, we have reached the larynx. This is the thyroid cartilage. And even here, you can see this inflammatory phlegmon, soft tissue thickening. And then you look carefully and you see that there is a bubble here. There is an air bubble here. This is the key, edge of the film. So this is the beauty of this case, that you could see from where it is coming. And you can then ask for the next investigation, which of course was a CT in this acute context. And then you look carefully, and the jugular vein is thrombosed. It's long-standing thrombosis. Now, of course, the brachiocephalic, if you see the brachiocephalic, the left brachiocephalic, that is not opacified, which makes sense. Now, as soon as we pick this up, we go for something upstairs. Now, first of all, think out of the box. What's happening? It's a transspatial thing. So what is happening? Dental should be up there as a cause. And of course, you can ask for bone window. And I'm not showing you coronals or sagittals where you can see the same thing, though there are dental artifacts. But if you look carefully, look here, look at this one. And there is nothing in this socket, and there is this abscess actually sitting in the mandible. Now, with that, you can see this inflammatory phlegmon. The word phlegmon, whenever in head and neck, you see enhancing inflammatory tissue, use this word phlegmon. And when you have got necrotic tissue, which shows rim enhancement, which is liquefied, use the word abscess. So these two words should go together. So part of it is phlegmon. You can see, look at the soft tissue swelling versus this side. And within that, there are abscesses. And these abscesses are multifocal abscesses, which have got air bubbles also. Now, let's go back to anatomy and try to trace it. Which space is involved? Now, from here, of course, from the submandibular space, it has gone to the masticator space, to the parotid space, but most importantly, to the carotid space. Now, this is the the common carotid artery, abscess there. Let's go to the base of skull. So we are going superiorly. And this is the internal jugular, the jugular foramen. You don't see any vessel there, means it's thrombosed, and you can see air bubbles. So you can see air bubbles going all the way here and touching the base of the skull. And as we go down, now this is the posterior cervical space, and you can see air bubbles going into the posterior cervical space. So infection also going down. Now, as we trace it, of course, these spaces we have already covered. You can see a lot of edema. We have reached the hyoid bone. Now we are in the hyoid bone. Abscess here. We continue downwards. Look at this, lot of soft tissue. So this, by definition, will be the visceral space. Remember this. So the infection is also involving the visceral space. Here, we have reached the thyroid, and the infection is sitting here. You see this abscess is sitting there. Where is this? This is in the carotid space. And you will agree that the epicenter is not involving the visceral space at this level. Slightly more superiorly, it is involving the visceral, but it is not in this region. And now, as we go down, look at this abscess, and now it makes sense. We have gone to the supra arch, the great vessels in the mediastinum, and you can see the abscess is there, and it is encasing the left common carotid and the left subclavian. So this case has got so many teaching, points, and particularly regarding anatomy and the concept of spaces. You must remember the key point that head and neck infections can go into the mediastinum. So retropharyngeal space, have seen that how carotid space connects with the anterior mediastinum, and similarly the visceral space also connects with the anterior mediastinum. So retropharyngeal abscesses also you must keep in mind. Okay, so this was a teaching case for today. Rest of the cases, I think the teaching will be much less. Okay, candidate 2, are you with us?
Yes, sir.
Now, this is a 81-year-old female, A&E case, loss of consciousness in lounge, so not a road traffic accident, hit her head. So the patient also is on anticoagulants. So they want to rule out intracranial hemorrhage. Simple as that. Over to you.
Okay, sir. I'll just request the remote.
Yeah.
So I've been provided. Yeah, now I'm able to scroll. So I've been provided with the NCCT sections, brain sections of this elderly patient who has sustained injury and is on anticoagulants. So I'm going from top to bottom. So in the first look, I've not been able to see any area of an obvious bleed, but here in the basal sections, I can see that there is a lesion. There's a little bit of lag. There is an expansile lesion within the bone. There's a lot of lag, so I'm not able to scroll properly.
Yeah. So which bone it is?
It is mandible.
Okay. So what would you like to do for that?
So this is probably an incidental finding. But I like to see the brain also to look for any area of bleed.
Yeah. So
Although
there
in the
was no
first
bleed,
look I was
no
not able to
bleed
see.
there. You know,
Sorry, sir.
in the brain, there was no bleed. That's fine. I'm more interested in this lesion which you had picked up. What are
Okay.
you going to do? What this is?
I like to see the bone window also.
So this is the bone window.
Okay.
Let me show it for you.
Yeah, I'm not able to scroll. There's a lot of lag.
But this is it. We don't have more than that.
Okay. Um, so can I see the soft tissue once again, sir?
Sorry, just 1 second. This is it. This is the last slide.
Okay. So this seems to be in the expansile lesion in the mandible, and seems to be benign, because there's no obvious bone destruction which I can see, and so this does not look like doesn't show any obvious aggressive features. So I'd like to get this evaluated in detail on further imaging to be able to finally comment about the possible differentials regarding this. But on these basic imaging, limited images available, it seems to be benign.
So this is a further CT scan.
Okay. Okay, so can I see the sagittal sections? I want to see the relation of this lesion in
Tell me
tooth,
relations with what?
relation with the tooth.
So you tell me the relation on this axial.
Yeah, there is a tooth within it, so it can be it can be a periapical cyst. What is the age of the patient?
81.
Okay. So it can be a periapical or dentigerous cyst, since I can see it in relation to the tooth, but like on the sagittal sections, I like to see whether it is related
You
to
see it on the scout?
on the scout images. I can see that it is probably related to the root of the tooth, so it can be possibly be a periapical cyst.
What is a periapical cyst?
It is related to the root of the tooth, and
what is your differential diagnosis?
so normally in relation to dentition, we see periapical and dentigerous cyst. So if the root is involved, then it's a periapical, and if the crown is impacted, it's a dentigerous.
Okay, we stop there. Thank you.
Okay, sir.
So this case was for, again, observation. So this was a dentigerous cyst, and of course, the key thing here is, as in the first case, the viewing protocol. Candidate, can you please switch off your mic? I can hear a bit of a background noise. Now, this is the key point is your protocol. The candidate did very well. Picked up the lesion, which is an incidental lesion, and there was nothing else in the brain. I was not interested in anything else. And please also always remember this: base of skull, orbit, etc. Now, lytic lesions in the mandible or maxilla, this is the differential diagnosis. So candidate two, one of the thing is that you were mixing up the concepts of periapical cyst, which is because of the caries, and that's a totally different radiological appearance versus a dentigerous cyst. So you know, periapical cyst is the one, this one. Periapical is this one, also known as a radical cyst, well-defined, ovoid, dead non-vital tooth. So you will basically see a caries and or some dental work done, and at the base of this will be the periapical cyst. So this should not have been discussed in the differential diagnosis of our case. Interestingly, our case was 80-something year old. Still, it was a cyst which was arising from unerupted tooth. Now, what is the pitfall? The pitfall is an ameloblastoma. Please remember that ameloblastomas can also be possible associated unerupted molar tooth. So please remember this. But counter argument is that in ameloblastomas, they've got a bubbly appearance, and so bubble type of appearance will be there. So our case was not like that, but always, I want to see your thought process. What else? Because it was an unilocular cyst. It was not a multilocular, multisubtated cyst. But was it totally what we call cystic? We are never sure on the CT scan. And so with that, we go back to the basics, and this is where it was picked up. Now, is there completely cystic inside? We don't know. Of course, then we did a CT scan, and here it looks like an expansile unilocular. It's not so bubble or anything. But then on this CT also, it confirms. Will you stop there? No, you will not. Basic concept is, particularly this is because of the age of the patient, you have to make sure that it is cystic. Now, in this case, I could have actually given you a viva on an MR of the brain. Interestingly, this MR was done for this patient for some other clinical context. And so this can also be shown in the exam. Now, the key thing on this MR is that you can barely see it here on this flare sequence. It's a bit harsh to, will you pick it up on the last slice or not? But it doesn't become harsh. On an MR, the coronal sequences and the sagittal sequences show a lot of head and neck. Remember that. Lot of head and neck is visible. So you can see this, and this is a classical exam case where there is tongue here. You can see the left hemimandible, right hemimandible, and you can see this expansile lesion on the right side. There is some low signal on this T2 weighted sequence. This might be blood products. And on this MR, there is a sagittal. Now look here, this is what is going to be asked in the exam, the protocol. So you are going right and left. So this is the mandible, and look at this mandible with this, unerupted tooth. So this was a dentigerous cyst, quite a unique presentation at this age. But are we sure? Is there any enhancing nodule inside? For example, this. In this era, people will do an MR for this. MR with contrast with fat saturation. And sometimes because there is high signal here, you will not be very sure. But having said that, how do you handle a case of expansile lesion in the mandible? This is the main point. You have to make sure that there is no enhancing soft tissue component. So key points here in this case here are that satisfaction of search, both on CT, both on MR. And then the differential diagnosis of expansile lytic lesions in the mandible. And then the differential diagnosis of, the concept of how do you characterize these lesions, particularly to make sure that there is no enhancement. So please remember, ameloblastomas will have solid components and they will enhance. Okay, candidate 2, well done. I think your first case had 3 actually components, so that is it for you. Thank you very much.
Yes, sir. Sir, I have one question regarding the second case.
Questions in the end. Right now, I don't have time. I don't have any time. So
you,
just you can ask me in the end. Now, second thing is that in the exam, please remember that each case, each modality is marked differently. So for the chest X-ray, it will be marked separately, and the what we call the CT will be marked separately, and the second CT will be marked separately. So next candidate 3, are you with us?
Yes, sir.
Okay, candidate 3. This is a 68-year-old female. She has presented with foul-smelling pervaginal discharge, high CRP. People are worried about complex diverticulitis. And then, so that is it. Over to you.
Okay, I will request the remote control.
Yes. Just one
So,
second. I think
I'm
you
sorry.
have, I will, let me change it back. Over to you now.
Okay.
You know, if don't, you can also work through your what we call keypad
Um,
to scroll it up and down. In any case, please try it, whatever you are doing.
okay. Okay, I'll use the bar above. Okay, I'm presented with axial CT scan of the abdomen and pelvis with IV contrast. I'll go through the whole cuts first and then go back to my findings. Okay, unfortunately, lower cuts of the pelvis, most inferior cuts, are degraded by streak artifact by previous total hip replacement, but okay, there is a complex area, mainly of soft tissue component with central cystic area, and an air locule seen at level of the lower rectum and anal canal. The colon proximally is not dilated. I'm sorry. The scroll is moving fast. I'm sorry. First, I would like to confirm that this is arising from the anal canal or from the vagina, since the female has full smelling vaginal discharge. The urinary bladder seems to be pushed anteriorly. Can we like adjust the window, or it's not allowed in
No,
the...
there is a lot of artifact. There is, it will not help you. So there is a
Okay,
lot of artifact, but whatever you want to say, you have to say it on this window.
on this, okay.
Do you want to see another
Can we
plane?
see the sagittal plane, please?
Okay, here you are. Let me slightly shift it for you.
Okay,
Over to you.
thank you.
Let me scroll for you. Let me just leave it. You leave it.
Okay.
I will scroll for you. Please remember on one side there is a bit of artifact, so this will
Yes, the
yeah.
left side, and then going to the right side. Okay, there is a complex.
I will once again scroll through the axial.
Axial.
Keep talking, please. Give me your conclusion. Give me, just sum it up, please.
Okay, I'm trying like to trace the rectum. I think there is concentric thickening involving, or it's posterior there. Can we go down again, please? Okay, there is concentric thickening in the anal canal and lower rectum. Can we go up? There is also like a fluid, or is it a large air containing at site of the vagina, but I can't with the artifact.
Right. So till now, what is your conclusion?
I'm suspecting a rectal mass or a complicated
What would you like to do next?
MRI.
Okay.
Okay, so I'm presented with pelvis MRI, T2 axial images. Okay,
So I've gone up. I'm going back once again.
okay. There is a complex rectal mass that is mainly involving the almost circumferential, however asymmetric, and I think it is invading anteriorly through the anterior wall of the lower anal canal and reaching the vagina. But the urinary bladder is pushed anteriorly by the mass, by mass effect. Okay, and coronal.
I'll show you a sagittal. This is a sagittal.
Okay. Okay, here I can see the uterus. So the uterus is invaded by the mass, and there is a large, what appeared on the CT scan, air containing. There is a large air in the uterine cavity as well. I'd like to check if there is any lymph node enlargement and if there is any involvement of any other
What
structures.
is your conclusion? Just give me your conclusion.
I'm suspecting a rectal mass with involvement of the invasion into the rectouterine pouch of Douglas, and then involvement of the posterior wall of the uterus. Presence of air also indicates the invasion in the endometrial cavity.
So what is this high signal intensity focus?
Okay.
What do you say again?
Well, I assumed it is the lumen or necrotic part of the mass.
Necrotic part of the mass.
It's like if it is high signal on T2, so fluid.
in a rectal carcinoma, if you see this high signal like this.
Could it be mucinous? Well, mucinous would show low signal.
Mucinous. Okay, thank you.
Thank you.
So this was an observation case, and this observation case is mucinous carcinoma rectum with vaginal invasion. So, and in this case, generally speaking, it was quite tricky on the CT scan, but a bit of fine touch. Now, on the CT scan, please also remember in the exam what happens is, particularly in the long cases, in the viva also it happens, that the examiner in the long cases also, they give you, only some sequences. For example, it is their right to just give you an axial sequence. End of story. So at times you don't have the luxury to see everything on every sequence. So you have to develop your anatomy. The key learning point in this case is develop your anatomy on all sequences, particularly the axial sequence. Now, this particular case was very tricky because of this artifact, which I do understand. Now, if you go distally, now this is the anal canal. On a CT, anal canal is never seen very well. But one thing is that here you can infer that there is a mass, it is posteriorly placed. So here it becomes absolutely clear that it is very posteriorly placed, so it must be from the rectum. Now, with that, there is air here, and the urinary bladder is a key structure which is sitting anterior to that. Now, if we go superior to that, this is uterus, but of course you cannot make it out on an axial CT scan. So if we go to the sagittal, here the mass is sitting here, but overall, nobody is expecting you to pick up everything. Having said that, if you see, this is the vagina, which has got air. Superior to that, this is the uterus, and this is the urinary bladder. And now on this T2 weighted sequence, anal canal is very distal. And the key structure which you have to remember anterior to the anal canal, so this is the anal canal, is the vagina. Now, this is the vagina. And this vagina is not normal. Even here, something is wrong. You have to develop your anatomy. And these high signal intensity foci here are abnormal. As we go more superiorly, the rectal carcinoma is visible, and then, it just blows up because this is a mucinous cyst adenocarcinoma. It has gone into the vagina, completely eroding it. And there is a air, means a fistula, and this air is in the vagina. And most of the tumor here anteriorly is sitting within the vagina. And superior to that is the uterus. So it is not invading the uterus. Also, this is the uterus. And of course, the bladder is displaced anteriorly. Now, if we go to the sagittal, which is this one, we can see that this is the anal canal. So from here onwards is the vagina. And you can see this mucin material, it is going distally in the vagina, and that is what we were looking at. Here, this is the posterior wall of the vagina. This tumor has gone completely inside, sitting in the vagina. As far as the uterus is concerned, this is the uterus, and it is a postmenopausal uterus. This is the cervix. This is the endometrium. This is retroverted. So it looks fine. It is not invaded by it, but whole of this vagina is invaded. So this was also a pattern recognition type of a case, nothing special. And mucinous carcinomas, they have come in the exam, and this concept is that mucinous tumors will have high signal, as in white signal, and they will, the prognosis wise, they are bad. They are, it's taken as a worse off sign. There was a PET scan, which is irrelevant for you, but I think it was just downloaded, so we will skip it. Over to you, candidate.
Yes,
Three.
sir.
Over to you. So this is a 83-year-old female dysphagia.
Okay, I'm presented with AP chest radiograph of a skeletally mature patient. There is, first of all, there is a left-sided pleural effusion with collapse of left lower lung. There is also a widening of the mediastinum with air-containing structure. Like there is a air column seen just to the left side of the trachea. Suspecting a dilated esophagus, as the air column is irregular, so there might be esophageal thickening. I'm checking the lung for evidence of any. There is some tiny nodules bilaterally at the lungs, but I would prefer to zoom in to check them more properly. So to summarize, there is a mediastinal widening with air-containing structure, likely esophageal dilatation. So I would take the case further with barium swallow.
So I will just show you a few I don't want you to waste too much time on this. Some sequences of a solo which we did. This is the distal end, and it. What are your comments on this?
The esophagus is dilated down to the lower esophageal sphincter. There is irregular narrowing, I'm suspecting. And
is there narrowing here? It's not a very good quality film.
no,
Yeah, but having said that, there was no narrowing in this region.
not at the lower end.
Yeah, not at the lower end, but it is a dilated. What comes to your mind now?
Okay, so dilated esophagus with patent, with no, let's say, no narrowing at the lower esophageal sphincter. So I can think of scleroderma or pseudoachalasia would, I would expect
What is
narrowing.
pseudoachalasia? What is pseudoachalasia? Achalasia.
Achalasia is widening of the esophagus due to a distal tumor at the lower esophageal sphincter or at the gastroesophageal junction.
So what would you like to do next?
If no narrowing is apparent on these images, I would like to arrange for upper endoscopy and for chest CT scan with IV contrast. Okay, I'm presented with chest CT, abdomen and pelvis chest CT scan with IV contrast. This shows a massively dilated esophagus with air debris leveling at the upper and mid part of thoracic esophagus. down. The esophagus is dilated down into the stomach, but the stomach shows a almost symmetrical mural thickening and in luminal narrowing. So I'm suspecting linitis plastica of the stomach.
Okay, thank you. Well done. So this case is a case of yes, and once again, announcement about this course where we are going to Dubai Rashid Hospital, 31st of August, 1st September, extensive one-to-one viva practice course. You will get 6 hours of viva. And you will also be able to observe viva of your buddies, your partners who will be with you. So it's a huge event. Those of you who want to improve your viva skills. For registration, these are the organizers, dubaifrcr@gmail.com. You can email them for details. I think many of you have registered, but I think there are still some places left. So take advantage of that. Now, this is pseudoeclasia due to linitis plastica, carcinoma stomach. Now, a few things. Linitis plastica. What is linitis plastica? Look at this picture. And look at this picture. Basically, what happens is that linitis plastica is that there is a diffuse tumor, submucosal spread of the tumor with fibrosis. It is serous type of carcinoma. But please remember that there is a differential diagnosis. Gastric carcinoma is the most common. Lymphomas can cause this. Metastasis, particularly breast metastasis, can cause this. And there are some benign conditions which can also be considered in the differential diagnosis. So this is what we are talking about. If you can see here, this is the normal mucosa, submucosa, muscularis mucosa. Of course, on each study, you might not see it, but having said that, you can see this is what we call serous gastric carcinoma because of there is no stratification. It is all a single type of enhancement. And this is how it looks like on a a gross specimen. And this is how it looks like on a barium examination. Basically, you will see loss of rugi, loss of normal mucosal pattern, and there will be loss of distensibility. Loss of distensibility is a key finding on a barium examination. And with that, now please remember that this is a favorite type of a case in the exam where they will show you eclasia. And at times this eclasia will be more subtle than it is visible here. There is widening of the esophagus, and the candidate did well. We are asked for a barium examination. Unfortunately, this is not a very good quality examination. The patient could not cooperate, but having said that, actually the distal end is not very well visible, but the key point is that it was not a classical rat tail or anything. And then CT, the correct answer was CT. With that, of course, what we call endoscopy. That is the correct answer, which the candidate also mentioned. So here you can see, look at the esophagus. And one thing which I want to point out is that eclasia is usually young age group thing. So this was not a young age group. And we can see that this is dilated tortuous, which goes all the way all the way to the stomach. And then we can see the picture of linitis. Okay, well done. Candidate 3, are you with us?
Yes, sir.
I think there is a lag in what I am showing and what is visible to you. I'll come out of it and then show it once again. You can see a MR
Brain
of...
dry flare cut.
Yes, over to you. So let me tell you that this is a 46-year-old female, came to the hospital with headache and vomiting, and with that photophobia, and rule out subarachnoid hemorrhage, rule out meningitis. This is the differential which they have given.
Okay. I'm presented with axial flare images of the brain. I'll go start from the top, then down. And I can notice that there is subarachnoid space hyperintensity on flare images. I'll go through the rest of the images and okay, the hyperintense signal at subarachnoid spaces is mainly at both cerebral convexities. I'm suspecting some loss of gray or decrease in gray-white matter differentiation at left parietal lobe, but I would check the window and check DWI and T2 to confirm that.
You want to see DWI and T2 for what?
I'm suspecting that there is decreased gray-white matter differentiation at left parietal area.
Okay.
So in my routine practice, I would window the image and check the T2 and DWI for that. Okay, so my differential diagnosis for flare hyperintense subarachnoid space would include meningitis, would include subarachnoid hemorrhage, and there is artifactual causes like or oxygen therapy. I'd like to see T1 weighted images if available, and if there is any previous CT scans done for the patient, I would review them as well.
There are no CT scans done. Just hold on, please. Leave them for me. So I've got a T1, but this is a
Sagittal T1. Okay, I'm presented with sagittal T1 weighted image without IV contrast of the brain. Go-
Do you see anything where
I can't appreciate any hyperintensity at the cerebral convexities, so
what would you like to see next?
I'd like to see flare post-contrast images to confirm
Here.
meningitis. Yes, flare post-contrast for the possibility of meningitis.
So this is a post-contrast T1.
T1. Okay. The dural venous sinuses are well enhanced. Well, I can't appreciate much leptomeningeal thickening, maybe some here.
So I've gone to a coronal.
Coronal, yes. This is a
Wow.
coronal cut. Well, I can't appreciate much leptomeningeal thickening or enhancement to
So,
suggest meningitis.
so
Okay,
then
so I would check with the treating team if oxygenation was given before the before imaging.
not at
And
all.
not at all.
Patient came from home.
Okay.
So what is the conclusion?
Well, still, I would choose meningitis over subarachnoid hemorrhage in such a case.
Why do you say that?
There was no there was no hyperintensity on T1, and
Can you check anything else?
normal.
Any other sequence?
Sorry,
Any other sequence you can check?
SWI or G. Oh, there is blooming artifact at both subarachnoid spaces corresponding to flare hyperintense signal.
So what is your conclusion now?
Subarachnoid hemorrhage.
How can you explain that? 46-year-old female.
46-year-old female. So if the patient if the patient like is anemic, but that would cause the CT hypodensity.
Can this happen, by the way, in a 46-year-old? Spontaneous.
Spontaneous subarachnoid hemorrhage.
Okay, just conclusion is that this is subarachnoid hemorrhage or not? What is your answer?
Yes, I'd say this is subarachnoid hemorrhage.
Okay then. Thank you. Now, am I going the other way around, isn't it? So, incidental subarachnoid hemorrhage on MRI. Now, key thing is that there is a differential diagnosis which is very important for your exam. Sulcal flare hyperintensities, and this is where the viva will start, or the first sequence which will be shown to you will be a flare. Hyperintensities on flare sequence can be seen in leptomeningeal and or CSF pathologies. And now the differential diagnosis, of course, is given here, but the key thing for you to remember is any leptomeningeal processes versus subarachnoid hemorrhage. And here we can leptomeningeal processes include, what does it include? It can include carcinomatosis, as in tumors, metastases, and primary tumors like GBM, etc. And then bacterial meningitis like TB, etc. And please do not remember these fancy things. Aseptic meningitis, which includes things like sarcoidosis, which is the greatest mimicker in neuroradiology, Wegener's rheumatoid arthritis. So they can give you long cases if you know this knowledge. But subarachnoid hemorrhage, what happens is that there can be subarachnoid hemorrhages which are slightly old, as in 4, 5, 6 days old, not seen on CT scan. And sometimes these patients do not present initially. And I'll give you the concept in the subsequent slides. And they might come to you after a few days. Look at this. This is a very good case where compare, for example, this sulcus on a flares versus this sulcus. and see the CT scan done on the same day. And you will agree that you don't see anything on the CT scan, but on this flare, you can see this high signal. This is what we are talking about. So now comes this concept. This is an extremely important concept, which please remember or try to listen with a lot of concentration, because you will do mistakes if you don't have this concept. You know, people think that subarachnoid hemorrhage, traumatic subarachnoid hemorrhage is the most common cause of subarachnoid hemorrhage. And otherwise, there is aneurysms, and otherwise there is, the peri-mesencephalic. But those ones, anatomically speaking, are at the basal cisterns. But do not forget this type of, which is around the convexities. We call it sulcal subarachnoid hemorrhage or convexal subarachnoid hemorrhage, and the pathology is different, which I'll show you. It is a unique type of subarachnoid hemorrhage, localized to sulci over the top convexity of the brain, and spares basal cisterns. Now, this slide, this is from StatDX. So I think you must remember this, the pathology. What is the etiology? Most common etiology varies with age. In elderly patients, it is amyloid angiopathy, 50%, or venous thrombosis, vasculitis. In middle-aged, reversible cerebral vasoconstriction syndrome, vasculitis, vein thrombosis. In young patient, look at this one, drugs, vasculitis, veins, dural sinus thrombosis. Basically, just remember it like this, that any condition which can involve the vessels, the small vessels, may it be veins or small arteries, they can leak and they can cause subarachnoid hemorrhage. So this etiology is very important for you to remember. And clinical issues, 7% of all spontaneous non-traumatic, can you imagine? Out of 100, 7 of them will be sulcal subarachnoid hemorrhage. Most common, middle-aged woman, just like our patient. And look at this. Look at the clinical context. And this concept is important for you to remember. Presentation varies with age. If it is less than 60 years, it can be sudden, thunderclap headaches, but more than 60, transient sensory or motor symptoms, less intense headache. And these are the type of cases which I have seen in my experience, less intense headache. People just remember it that subarachnoid hemorrhage, the classical symptoms are the worst headache of my life. So that happens, of course, definitely it happens. But do not forget that subarachnoid hemorrhage can present with less intense headache. And these are the type of patients, when they come to the hospital, by the way, I did not tell the candidate, she was asking for a CT, which was absolutely fine. We did a CT was normal. And after this MR was done, I'm not showing you the CT for the simple reason that it's time-wise, it will be a wastage. Convexal, what is the diagnostic clue? Hyperdensity in one of more dorsolateral convexity sulci on non-enhanced CT and hyperintense sulci on flare sequence. It can be, look at the topmost slide, cuts, and unilateral, or it can be bilateral also. Look at this picture and just remember this picture, and then you will remember everything. This is from StatDX. And you can see where it is sitting. And this is an example from StatDX. And this is an example from my collection, where there is a subarachnoid hemorrhage, and we did not know why it was there. Must be something which I have told you. And this is another example where there was no trauma or anything, and there is sulcal, these subarachnoid. These were picked up on a CT scan. But here comes the differential diagnosis. Differential diagnosis of meningeal enhancement. Please remember, that meninges are two types. Rather, there are three meninges, but there are two pairs. So dura mater, arachnoid matter, and then the pia mater, which is adherent to the brain. It dips inside. And you can well imagine that this is the sulcus. You can well imagine if the pia mater will be involved, then there will be enhancement here, and this enhancement will go into the adjacent gyrus also. Together, the dura mater and the arachnoid is known as pachymeninges. Together, the arachnoid and the pia is known as leptomeninges. Leptomeninges, they go into the sulci, remember, but the pachymeninges, it does not. So this is one of the most important differential diagnosis for your exam. And similar to the CSF1, you know, the sulcal high signal intensity, that pachymeninges versus leptomeninges when there is enhancement, what can be the causes? Other than the details which are given here, there are what we call, carcinomatosis, then infections, bacterial and in TB, etc. And then comes the aseptic meningitis, which I refer to. These are extremely important. For example, sarcoidosis, Wegener's, rheumatoid BSIDS, or all of these things are very important. And some of these are, of course, infections. Now, look at this case. So the key point to remember is that in your clinical practice, and this is what will happen in the exam. The examiner is going to show you sulcal high signal on a flare. They will start with a flare. And when you pick up this high signal on a flare, give contrast. This is your first answer. I will give contrast. If there is any enhancement, you have got the differential diagnosis of leptomeningeal processes. If there is no enhancement, subarachnoid hemorrhage will be one of the differential. You can take the help of, let's say, SWI sequence, like our case. In this particular one, there was high signal on the flare sequence. This is pre-contrast, this is post-contrast, and you can see that there is enhancement. So on the sagittal post-contrast, you can see these leptomeningeal enhancement, which is also enhancing the adjacent gyri. So let's go back to our case here, which is, here you are. So you can see these are the foci of subarachnoid hemorrhage. And this is like your stat DX case, isn't it? But stat DX was unilateral. This is bilateral. And if you go for SWI, here you are. SWI at times will not be as helpful. Please remember this. So I've seen quite a few of them. In this one, the subarachnoid hemorrhage is quite thick and chunky. Sometimes it is thinner than this. Then on SWI sequence, the vessels which are the leptomeningeal vessels are also low signal. So you will not be able to convince yourself. So I warn you on this. But in our case, because it is slightly globular, it is helpful. And on post contrast, it did not show any enhancement. So this is a vibe sequence, 3D sequence. So we can make a axial, coronal, and sagittal out of it, and it did not show any enhancement. You remember somewhere here, maybe if we stretch our imagination, this is where it was, one of the sulcal, yeah. And one thing which I want you to see is the behavior on a DWI sequence. So let me, yeah, this is a DWI. Please remember that hemorrhage, subacute hemorrhage, can be high signal on DWI sequence. And this is how it looks like. It is quite a sensitive one, but don't think that I'm trying to tell you that always look at the DWI sequence. It can show there is a lot of material on this, which kind of hemorrhage will be bright on DWI. But in this particular case, you can see that this was bright. And actually, there is a focus sitting here also. So this was subarachnoid hemorrhage. Okay, last candidate. Well done, candidate 3. Last candidate, candidate 4. Are you with us? Let me check. Yes, candidate 4 is with us, but I think not a co-host. So I have made a co-host. Candidate 4, are you with us, please? You can unmute yourself.
I can hear you now.
Okay.
Thank you.
Okay. So now this is 67-year-old weight loss, rule out malignancy.
Right, sir.
Just concentrate on the pelvis, please.
Sir, can I take the mouse control?
Yes, yes. Ask for it. So the mouse is with you now.
Sir, I am presented with a contrast enhanced CT chest, abdomen, and pelvis. I will concentrate on the abdomen and pelvis images. The liver is normal. The pancreas also appears to be normal. Kidneys appear normal to me. And as going downwards, there is non-specific bowel gas pattern. And as we are going further downwards into the pelvis, yes, sir. Here I can appreciate that in the pelvis there is an abnormality, and this abnormality is a cystic lesion in the pelvis, and this cystic lesion appears to me that it is a dilated bowel segment. Sir, can I get the sagittal images?
Over to you.
So this is a well-defined lobulated cystic lesion, which is anterior to the rectum, and it is posterior to the uterus.
What would you like to do next?
Sir, next I would like to have a MRI of this patient.
Okay, here you are.
Sir, again, this is a T2 weighted sequence in which I can appreciate a well-defined lesion which is posterior to the uterus and interior to the rectum, and it is hyper intense, predominantly hyper intense on the T2 weighted sequence, and there are hypointense areas within this hyperintense lesion, and sir, can I have a stir sequence or fat suppressed T2 weighted sequence?
For what? What do you
Sir,
want?
I want to see whether these hyperintense signals are due to fat or
It is not fat. Not fat.
it's not fat. So if it's not fat, then the possibility is that it's a fluid cystic lesion, and this cystic lesion is lobulated, large, uh, between the uterus and the rectum, and the epicenter of the lesion appears to be that it's an adnexal lesion, and its origin appears to be uh, in the ovary. And sir, what's the age of the patient, can I ask?
77.
77. So my differentials for this lesion will be, it is a serous cyst adenoma of the ovary, and the possibility of
1 second, please. 1 second. What structure is this?
this one, sir.
Yeah.
Sir, this is a bowel. This is a segment of the bowel, and most likely it's a so it can be most likely it can be sigmoid colon.
Right. So what is your conclusion?
So sir, it's a cystic lesion which is involving the sigmoid anterior to the rectum and posterior to the uterus. So to me it appears to be adnexal lesion will be my first differential. Then I would place, it can be have origin from the sigmoid, it can be the mucinous or the adenocarcinomas of the colon, but they are usually more aggressive if they are of that much size.
Okay, then. Thank you. Thank you. So this case, so sigmoid carcinoma mucinous with large exophytic component with colo-uterine and colovesical developing fistulae. And this is the type of case which can come in the viva, which can come as a long case also. And how you tackle it is how you will get the the marks. So the case is easy. But what I mean is by easy is that the case, anybody can pick up the case. But then the findings. Now, on this CT scan, what we can see is that there is a mass here, and this is the rectum. The mass is in between the uterus and the rectum, and looks very well rounded. If you see the uterus, you can see that the myometrium here is, indented by something. On a CT scan, you cannot characterize it. But now, if you see here, anterior to the uterus is the urinary bladder. In the urinary bladder, there is a air bubble. And all of these things will carry marks. Remember that. And this edge of the urinary bladder, there is air bubble and there is some enhancement. We will see. Now, as we go superiorly, so let's trace the sigmoid and the rectosigmoid. So this is the rectum where my mouse is. As we are going up, we go right and left, and then ultimately we reach this point. Here, this sigmoid is involved, and you can see this low density, which is going into the sigmoid. And then rest of the sigmoid superior to that remains normal. On a CT scan, of course, more than this is very difficult. But look at the surrounding structures. Now, this is the uterus, correction, the bladder, and there is a bubble here, bubble of air, and there is a bubble here. This is the uterus, and something is happening on this side, not very well visible. Now, we go to the T2 weighted axia. Again, this is where my mouse is the rectum. And then you can see that displacement of the sigmoid to the right side. As we go superiorly, as we go here superiorly, you can see this mass here. And now this is very impressive. This is wall of the sigmoid. And with that, this mucinous component, which is breaching the wall from here to here, there is no wall. It is coming out. And this material then is, it is similar went into the vagina. So this one is going down, all the way down into the pelvis. Now with that, this is the uterus. There is maybe a submucosal fibroid, which is projecting into the uterine cavity. Here, there is invasion of the uterus. And then this is the bladder, correction, this is the vagina, which has got an air bubble. As far as the urinary bladder is concerned, this is the bladder, and maybe there is an air bubble sitting here anteriorly. When we go to the sagittal, this is the air bubble I was referring to. But going back to the, actually, interestingly, there was a synchronous tumor here. Do you see this? There is a synchronous tumor sitting in the rectum. And with that, now you can see how it behaves and how it comes out from the parent, organ, which is the sigmoid. And the uterus itself, these are some cysts, some thickening in the endocervical canal, and it is definitely invading the uterus also. I did not show you a coronal, but let's see a coronal just for the sake of it. And you can see now this is the sigmoid. This is the sigmoid. And you can see how it is breaching the wall. And from here, from this epicenter, it is going down. So this is mucinous tumor of the sigmoid. Now, if you mention that my differential is ovarian, I will accept that. The counter argument is that ovarian, but it cannot be a serous cyst adenoma or serous. It has to be a mucinous. But anatomy tells you that this is not an ovarian. In differential, of course, you can mention that that is the second possibility. If I report it, I'll be confident enough of calling it the way it is. Okay, now candidate 4. This
Yes,
is
sir.
your second last case of the day. MR brain, 66-year-old, TIA clinic, visual disturbances. So the patient presented for TIA clinic, and on the DWI sequence, there was no abnormality. So in our hospital, what we do is, nice guidelines are that TIA patients should have an MR within 24 hours. So we have got one-stop clinics where they come, we have got special slots for them, even just 1 hour before the working hours start, and within 2 hours, they are seen in the clinic. So this is that kind of a scan. The patient on a DWI sequence was no abnormality, but had some visual disturbances, 66-year-old. I'm showing you a sequence. Over to you.
So I requested for the remote control.
Yeah, it is with you.
Thank you, sir. Sir, I am presented with the coronal T2 flare sequence of the MRI brain. In this sequence, I can appreciate there are abnormal hyperintense signals. These hyperintense signals are involving the subcortical white matter. These abnormal hyperintense T2 flare signals are randomly distributed.
So I'm not interested. Do you see any abnormality in the sulci?
Yes, sir. I can appreciate that there are T2 flare hyperintensities along along the sulci.
No, this is not the sulcus where you are pointing out. This is just a periventricular region. That is not the sulcus. That is not the sulcus. That is, the white matter around the occipital horn. Go posteriorly, please. Posteriorly.
So here, this is the hyperint.
I have told you this is not a sulcus. You are mixing up, and now look at the other side, please. Other side. This side, yes.
So this is a slight hyperintense signal.
So what do you think it is? Normal, abnormal?
So it is abnormal because it's not symmetrical.
Is it only one sulcus or more than that?
So it's more than one. It's also here.
Mm-hmm.
Here in this sulcus. Here along this sulcus. Here also. These are here also. These are hyperintense signals. And
what do you think? What will you do next?
so as you told that diffusion weighted is normal, and then I would go for the contrast enhanced, T1 weighted contrast enhanced sequence.
Post contrast, over to you. Have
Sorry,
you got?
I'm unable to.
Okay. So there are a bit of artifacts there. So let's go to an axial slice, which is this one.
Sir, I would correlate the hyperintensity to flare signals whether they are enhancing or not. So it can I have the dual window?
So no, dual window, unfortunately, you will not have, but let me first of all orient you once again. Now, if you see here, uh, there is an area. I did not show you this axial T2. So this axial T2, and then you can see in the occipital region, similar high signal intensity foci. Now, just a recap that here we are at the level of the body of the ventricle. There is this, and we have gone down, and here is the occipital lobe, and there is abnormal signal. Now on post contrast axial, which is this one. Now, for example, compare this with this. So there is a bit of artifact. There is a bit of artifact. But
Sir,
just see these gyri here. Is there leptomeningeal enhancement? Compare this with this.
sir, yes, there is prominence of leptomeninges, and it appears that
Now, if you want to be more convinced, look at this sagittal. Now, on this sagittal, we are on the left side, and now we are going to the right side. What do you think?
yes, sir, there is an enhance. There is enhancement of the
Potential there.
there is enhancement of the sulci. So if there are T2 hyperintense signals which are enhancing on the T1 weighted post contrast, my first differential that it would be an inflammatory and infective. It can be meningitis.
And what is the other differential?
So other differential uh, other differential, can it be a posterior reversible encephalopathy syndrome press, because it is normal on the DWI weighted images and the T2 hyperintense signals in the occipital lobe.
Okay, we stop there. So the point is this is the same or similar case which I had showed you earlier with a subarachnoid hemorrhage. And the key thing is that when there is leptomeningeal enhancement, key three headings which should be up there for you is, one is infection. And for infection, you will ask for CSF analysis, etc. Then is carcinomatosis, and then is aseptic meningitis, as in Wegener's and Behçet's and Sjogren's and rheumatoid, etc., and sarcoidosis, etc. So that is what you have to, elaborate, which is on this differential diagnosis. It's a very, very important exam case, and for which your differential diagnosis should be up there. Now, in this particular case, I showed you a flare sequence, and the beauty of this flare was that only at the edge of the film you can see it. Otherwise, you cannot see it. If you are very casual, this also tells you your reflexes, how you look at the coronal flare, and this is just the periventricular region. As we go more distally, look at the sulci and compare it, and then you can convince yourself that something is happening. All of these sulci are high signal. we recall the patient for another, the full study, because in TIA we just do limited sequences. And on this axial flare, once again, this of course can come in the exam, as I showed you. Sulci are high, and look at this versus this. And on post contrast, there were some artifacts, but I believe the most convincing one is the sagittal finding. And this finding should be etched in your brain, that how leptomeningeal enhancement looks like. And then comes the differential. Okay, your last case of the day. Now, candidate 4, are you with us? Another observation case. This is a 59-year-old diabetic, persistent UTI since 4 months. And I think complain of passing foul smelling urine, and maybe, yes, foul smelling urine. Please remember that there is a previous history of hysterectomy done for carcinoma cervix, previous hysterectomy. So the patient presented to A&E, and a CT-KUB non-contrast was done. First of all, just look at the bladder area, and please remember that uterine hysterectomy was done previously for a carcinoma cervix. So over to you. If you want to take the mouse, please ask for it. Yeah, just concentrate on the bladder area.
Sir, I am presented with the non-contrast CT abdomen and pelvis of a female patient. In this scan, I can appreciate that the urinary bladder is partially filled, and in this partially filled urinary bladder, I can appreciate that there are air locules and there are also perivesical fat strandings. The, the, the most important findings on this non-contrast CT is perivesical fat strandings, and there is an air locule which appears to be inside the bladder, and I would like to confirm it on the sagittal views if available.
Let me make it better for you. And just 1 second, don't move the mouse. So over to you.
Sir, I am unable to move.
So, yeah, so
yes, sir. So here so please stop. Yes. So here I can appreciate that the air locule is inside the urinary bladder, and there are perivesical fat strandings, and in the area of previous hysterectomy, especially in the area of the cervix, there is an ill-defined area, and I am unable to appreciate exactly the fat planes on the CT scan, and I would like to have the MRI pelvis of this patient. Yes, this is the MRI pelvis, and I can appreciate that in the region of the previous hysterectomy, there is an irregularly marginated, ill-defined mass lesion, which is obliterating the fat planes between the bladder and also abutting and at least abutting posteriorly to the rectal wall, and also involving the cirrhosis of the re- rectum, and it appears to be that it is a recurrent cervical uh, carcinoma which has caused a fistula with the urinary bladder, and it has caused air within the urinary bladder. So it is a uh, mm, fistula.
Can you see this sagittal now?
Yes, sir. In the sagittal, that there is also appears that the mass is invaded the sigmoid and it has, fistulous communication with the sigmoid as well. So there is a recurrent cervical carcinoma which has caused fistulous communication with the bladder as well as with the sigmoid colon. So I would refer the patient to the surgical MDT for further management.
And what is your differential?
Sir, as there was a history of previous hysterectomy due to cervical carcinoma, so my first differential that it is a recurrent cervical carcinoma. The other possibilities can that it can be a carcinoma of the newly developed carcinoma of the posterior wall of the urinary bladder. It can also be the carcinoma of the sigmoid, adenocarcinoma of the sigmoid, which has caused these appearances. But my first differential will be the same, that it's a recurrent cervical carcinoma.
Right. Okay, then. Thank you. Okay. So this was so your differential was fine. And I'll just go through the fine touch, but I will accept your whatever you told me. It is fine. Actually, it proved to be a sigmoid carcinoma, and it was not a recurrent, but the way you tackle it was absolutely fine. Both possibilities can be there. Let me show you a few fine touch points there. Now, on this CT scan, we can see that this was an ovarian cyst, which were later on picked up on the CT MR much better. Now, there was a air bubble here. This was a key finding. And this was the urinary bladder. Urinary bladder, if you see the outline of the urinary bladder is not normal, and there is a lot of fat stranding around it, means secondary infections or inflammation. Another point is vagina. Now look here. This is vagina. And you have to develop your eyes on an axial sequence for that. And in the vagina, you can see air bubbles. And this is an exam finding which you have to develop your eyes on, that there are air bubbles in the vagina. So something is happening. Then on the sagittal, this is the bladder. There is an air bubble there. And then there is a lot of soft tissue, as you mentioned. And this soft tissue is not abutting, it is adherent to the sigmoid colon. And so then in the vagina, there are some air bubbles even here downstairs. So then comes axial, this one. So this is the urethra, this is the vagina, the anorectal junction. We are coming up. And as we come up, this is the vagina. and part of the tumor, actually, you can physically see it invading the vagina on an axial. And this is what these sessions are about. Develop your eyes. You can see how it goes into. And now you can see it is going into the sigmoid. And one exophytic component is there. And you can see this air going here. And you can imagine the same thing on sagittal, how it will look like. Now, this is the urinary bladder. The tumor is invading. There is a gas bubble here, means that there is a fistula, ovarian follicles, left side, right side. And then when we go to the sagittal, this is it. Now, if you just imagine yourself with an annular apple core type of a tumor, this is what it was. As I pointed out, that if you say that this is most likely a recurrent tumor with secondary invasion, I will accept it, no issues. But actually, this was a sigmoid primary, a second primary, unfortunately, with with these fistulous communications, as elaborated. So this is what it is. These cases are simple cases, the rectal cases, which the pelvic cases, which I showed you today. This is what I call developing your eyes. And even in this exam, somebody got a rectal mucinous cyst carcinoma, but because had never seen a mucinous tumor, it became something very difficult. And that is why I showed you that sigmoid, exophytic type of a mucinous tumor. So many of these were, and you remember that diverticulum case where the bladder, in the diverticulum, the tumor was sitting, such a huge tumor. So this was just a bit of fine touch, and develop your eyes on axial anatomy. In the male, where is the prostate? Where are the seminal vesicles? Key point. In the female, where is the vagina on an axial? Uh, and where is the urethra if you go distally, etc., etc. So keep working on that. Thank you. Candidate two, if you are with us, you had a question. Sorry, I don't take questions during the sessions because there is too much to teach, and that is why, as a compromise, I don't take questions. If you've got a question now, candidate two, please. I don't know if candidate two is still with us or not. Let me check. So I've asked you to unmute. So if you want to ask. Candidate two, if you cannot, because I'm actually clicking on unmuting, but maybe it's not working for you. I did not show you a case of thoracic aorta intentionally because there was a lot of teaching involved in that. Maybe I'll show you later on I just skip it because of the time factor. Otherwise, that particular case will take half an hour. So I skip that. The case which was abscess. You remember the mediastinal abscess with neck abscess? That was a very long one. So I think it was equivalent to 4 cases. So that is why I curtailed the one. So candidate 2, Candidate 2, I can see you, but I cannot unmute you somehow or the other. So if you got a question, put it on the chat. Okay, so somebody has said, please cover the topic of acute aortic syndrome in detail next session. Actually, the case was about acute aortic syndrome, and I will do it next time. So we'll show you next time. That is what it was about. What was the differential of the last case? The last case differential was that either it was a recurrent tumor of the cervix with invasion of the the vagina and secondary invasion of the sigmoid. But actually, it was a sigmoid carcinoma which had done this, so a new tumor actually, unfortunately. So mucinous tumors, think like water. Mucin will be like water, as in very high signal, like urinary bladder, sorry, the urine, think like that. And so mucinous tumors will have that. How do you differentiate between leptomeningeal carcinomatosis and meningitis? Actually, you cannot. So what you will do is that you will ask for CSF analysis, and on this there can be differential. That is what it will be about. PCR, please remember, is a very good test for herpes, etc. But TB and things like that, at times it is difficult. Having said that, this is how you differentiate. And one of the viva scenarios can be that the examiner can say that on CSF analysis, there was nothing wrong, and clinically also they are not suspecting. Must ask for a CT cap, chest, abdomen, and pelvis, to rule out any. And that might be the scenario where they started with this, and as a follow-up case, show you some malignancy on the CT cap. Why was the dentigerous cyst high in T1 and flare? It was not a flare, it was a T2. On the T2, it had low signal, and on T1, it had high signal. Whenever there is high signal on T1, particularly in head and neck, maybe mucocele, things like that, please remember, because of high proteinaceous content, it can be high signal. But it can also be high because of hemorrhage. Because this particular cyst had internal high signal on T1 and low signal on T2, means hemosiderin, means chronic hemorrhage. So we will say that it had hemorrhagic component. So that is what it was. High signal on T1 is because of proteinaceous content or because of hemorrhage. But in this case, because the T2 was low, it is because of hemorrhage. In the last case, is there a fistula with the bladder? Yes, there was a fistula with the bladder. And GIST will not be like mucinous carcinomas, not at all. So don't go home with this idea that GIST will be like mucinous carcinoma. GIST will be solid. Even on a CT scan, you will pick them up. So DWI is always useful as adjunct, and tumors usually show restricted diffusion. But the mucin inside at times is only mucin, then it will not show restriction. But when there are fronds of tumor inside, tumor cells inside, then it will show restriction. But there is nothing special in DWI as far as mucinous tumor are concerned. Yes, it's a very good imaging tool. What I mean to say is that it's not a black and white. It will not be a game changer, though it increases your sensitivity. What else is there? How to differentiate between leptomeningeal? What characteristic signal mucinous? Really interesting. Quick review with key points, please, of cases done today. So the cases which were done today include basilar artery thrombosis. Number 2 was a carcinoma large carcinoma sitting in diverticulum of urinary bladder. Third one was gallstone ileus, where there was a fistula in the ileus and it stuck in the jejunum. Then there was an interesting case of anterior mediastinal abscess, and this was secondary to a dental abscess, chronic dental abscess, which has tracked into the mediastinum through the carotid space. And then there was a case of incidentaloma, mandible, where there was a expansile lesion. It was a satisfaction of search, which was dentigerous cyst. Then there was a regular pelvic case, mucinous carcinoma rectum invading the vagina. Then there was pseudoeclasia due to linitis plastica. Then there was subarachnoid hemorrhage on flare. Then sigmoid carcinoma mucinous with huge mass going deeper into the pelvis, into the cul-de-sac. Then there was leptomeningeal enhancement, another brain, and then sigmoid carcinoma with vesical fistula. So these were the cases. The chest X-ray finding in the mediastinal abscess were subtle, which were well picked up by the candidate, which was superior mediastinal widening. The most, should I say, obvious finding was that superior to the aortic knuckle, there was a new shadow, and that shadow should not be there. So that is what it was. Next session is going to be next Thursday. Okay, then I'll switch off my video and my mic, and I'll keep the feedback form